Great to see a lot of familiar faces as well as some new faces. And congratulations to everyone who found out that they matched today. It's a special day. And if you didn't match, I know it can be a challenging time, but we're wishing you all the best in the next steps, and don't take this outcome to define you as who you are as a person or as a physician. So we're really excited to be here for VMR today. And I can introduce myself first, and then we can go around and introduce our discussants, our case presenter, and then everyone helping us with teaching points and describing today. So I'm Gerline. I'm a internal medicine intern at Brigham and Women's in Boston and interested in cardiology. So I'm really excited to learn from the discussion today. And I'll pass it on to our discussants. We're so amazed to have them here and to learn from them today. Dr. Natasha Cuk and Dr. Lily Stern.
Hi, I'm Dr. Natasha Cuk. I'm one of the third-year cardiology fellows. I'm going into EP next year, staying at Cedars. And I did all of my training here in LA. So I was at UCLA for med school and residency as well.
And I'm Lily Stern, and I'm also a third-year fellow, and I'm going into advanced heart failure. And I actually did a year as a research coordinator with this group at Cedars, went up to San Francisco and was with Charmine as a medical student at UCSF and then a resident, and then moved back down here for fellowship.
Wow, amazing. And we love to ask our discussants what made you choose the specialty. So what made you choose cardiology, as well as what is something you like to do outside of medicine?
You start.
Oh, sorry.
Yeah.
Okay. So I think that year was pretty formative for me, doing that research year with the heart transplant group there. So always in the back of my mind, I was kind of geared towards cardiology, and I just always loved the physiology. And then heart failure in general is really, it just gets me really excited because I love the really intense relationships you have with patients, both inpatient and outpatient, that you kind of become their primary care providers on steroids, literally, and follow them over many, many years and become very close with them. And then in the hospital, you you get to be there with them during those, life and death moments, and whether you get to help them get this new quality of life that they didn't think was possible, or whether they end up going more palliative measures and you're able to be their guide through that. I just think that's such a powerful relationship to have with your patients. And then also you get to do procedures and inpatient, outpatient. So it's a good variety.
So I can kind of speak to EP because I think I was equally interested at the outset, like in EP and cardiology, and that's what kind of drew me to cardiology. And I think it's kind of the logic and the mechanisms and the problem solving that comes with rhythms, and the fact that, like, once you do that, like if you answer the question, like, what is this thing, what is going on, you'll be able to like tackle whatever problem, be it, on the floor with their tele and their device, or, or managing them clinically, or in the EP lab. And so I feel like it's a kind of callback to what, med school was all about, and the things that drew me to medicine. It was like, figure out the mechanisms, figure out what's going on, and like, you'll end up being able to get to the right answer and ultimately like help your patient. So, it's really nice to be in a field, or going into a field where, patients feel really satisfied if you can cure some really debilitating diseases. And that's really nice to see the patients do well on the other side.
Thanks so much for sharing. Oh, you forgot the second question.
Things we like to do outside of the hospital. I realized as you were talking.
I occasionally surf. I watch a lot of TV.
Yeah, Natasha's been known to take some trips to Costa Rica and surf for a week. She has to teach me.
Yeah, I'll take you next.
I like to sing. I used to play a lot of music and perform a bunch like 10 years ago, but now I love singing with family and friends, and that's just a special outlet for me.
And patients too. You've seen her, on the news and stuff.
Wow. Anna, do you want to introduce yourself next?
Hi everyone, I'm Kanu. I'm one of the internal medicine interns, as well interested in cardiology. Very happy to present a case on cardiology VMR. I learned a lot from this case, and hopefully it's a teaching case for everyone that we get to learn a lot from Natasha and Lily.
Thanks so much for bringing a case for us today. And Shema and Taylor, do you guys want to introduce yourself next?
So hi, my name is Shema. I'm currently a 50 medical student and I'm from Germany, and I have a very big passion for clinical reasoning and very excited for this session today. Mic to Taylor.
Hi, everyone. My name is Taylor. I'm a fourth-year medical student in Lake Erie College of Osteopathic Medicine, originally from Chicago, Illinois, and I'm your scribe today.
Awesome. We can start sharing the screen and then get started once that's up. And everyone, as always, feel free to put in your thoughts into the chat, any questions you have, any comments, anything you're thinking about as we go through the case. Are you able to share your screen, Taylor?
It says the host has disabled.
Oh, should have made you co-host. Let me try doing it again.
I can share my screen and allow you to scribe and do teaching points.
Okay, great.
Perfect, thanks.
Great, take it away, Connor.
All right. So starting with the first aliquot, the chief complaint, lightheadedness and palpitations. So it's a case of a 29-year-old female who presented to the ED with 1 week history of intermittent palpitations and episodes of lightheadedness. Lasted for about 30 seconds, feeling that she would faint. They have been ongoing as 5 to 6 episodes a day and for about 1 to 2 weeks. She denied any chest pain, any syncopal events, any loss of consciousness, any dyspnea, or any major neurological deficits.
Thanks so much, Kanu. Do you guys, what do you guys think about when you think about lightheadedness, palpitations? How are you thinking about it in terms of both as an internist and as a cardiology fellow?
So I think the first thing you can always start with, whether or not you know what direction you're going in, is just getting more details about like the quality, the events, you know, the surrounding situation. And some of that's already, you know, been fleshed out, which is great, lasting about 30 seconds at a time, 1 to 2 episodes per day. That's important because you kind of know how much, like if you're thinking forward to monitoring, like what kind of monitoring you can do, because you know those events are frequent enough that you'll hopefully catch them. And, you know, they're not causing significant hemodynamic compromise. She hasn't had any syncope, which is a really important question, but she clearly has, you know, pre-syncope with the lightheadedness. And so kind of, you know, I would also ask about some heart failure symptoms, chest pain, shortness of breath, dyspnea on exertion. Does she have shortness of breath, like with the palpitations? Sometimes people in clinic will describe it like as a catching in your chest and like a skipped beat. So it's kind of important with the palpitations. Is it a skipped beat? Is it multiple beats in a row? Is it very regular? Or is it kind of irregular? And sometimes you can kind of tap it out for patients and say, does it feel like it goes, or like, does it kind of skip around? And they'll be able to kind of work with you to give you those qualities. Those qualities helping you kind of differentiate between, you know, the different types of, you know, atrial arrhythmias, thinking like if this is an SVT, AFib, flutter, and then also maneuvers. So like, what have they done to abort these symptoms? Are they, you know, do they ever do any vagal maneuvers? Oftentimes people will do them, you know, without even knowing that they're doing them and say like, well, I'll bear down and it makes me feel better. And it's not like they've ever been instructed to do that. I once had someone describe how she would get, you know, sudden onset, fast, regular palpitations while doing like high intensity exercise. And if she stood on her head, they would go away. That's like another abortive potential maneuver. So that will also clue you into the type of rhythm if this is an arrhythmia, which of course are all the things I'm asking for, trying to get at rhythms with the palpitations, but all the other stuff, heart failure symptoms, also to figure out what the underlying substrate is. Is there some other issue going on that's driving the palpitations, or is it a primary rhythm issue?
Yeah, and just to piggyback on Natasha, that was exactly where my brain was as well. And Kanu, I think you said this is a 39-year-old woman, is that right?
29, 29.
Oh, 29. So it's a fairly young woman. So I think just to, in addition to thinking about the characteristics of what the palpitations are to characterize them, also just thinking about who is this patient? Is this a 29-year-old who has congenital heart disease? Does she have, some underlying structural abnormalities? Or is this just a normal 29-year-old with no medical problems who's coming in with palpitations? So the former I would be thinking more about, ventricular arrhythmias or certain atrial arrhythmias that are associated with certain conditions or associated with SCAR. But for a young 29-year-old, she may have more reentrant arrhythmias like WPW, or maybe she was drinking a lot last night, or over the past week has been, a binge drinking and or withdrawing and has AFib. So I think knowing who the patient is, learning a little bit more about the history is really going to help us direct what's going on here.
Yeah, and a great point about the triggers, so alcohol, coffee, other stimulants. I often ask them, do they drink energy drinks, and then do they take any over-the-counter meds? Sometimes people will take over-the-counter supplements with metabolically active ingredients and not recognize it. So those, and have you changed any of that lately?
And other things you always want to
Thyroid.
ask a drug history as well. Is she someone who does IV drugs? Does she use methamphetamines? Is this someone who, could have, infectious symptoms? And really these palpitations are from sepsis. So, again, we'll get a little more information and refine our differential.
Yeah, and then I quickly mentioned the thyroid, but a thyroid history, and we'll get kind of more into that as we're talking about exam and labs. And then, another word about over the counter, sometimes people will take nasal decongestants, and that can be a trigger for arrhythmias. So that's another question to ask.
All right, I'll try to cover most of the points that you guys want to ask in this. So
we went all out, sorry.
No, that's how I framed it. So she doesn't have any history of any recent fever, any chills, any skin rash, no nausea, vomiting, diarrhea, or constipation, no chest pain, no dyspnea on exertion. She does have these arrhythmias even when she moves and even when she's resting. So they occur every time. She didn't complain of any particular situation when they occur, no particular emotional exaggeration, no situation associated like micturition or defecation, no leg swelling. She doesn't complain of any joint pain or visual disturbances during these episodes, and no previous history of any syncopal episodes in the past. Coming to her past medical history, no previous history of any illness or hospitalization. She was never diagnosed with any congenital heart disease. She doesn't have any history of any previous surgeries. Meds, she takes Apri for birth control, which is desogestrel and ethinyl estradiol for birth control. Family history, her father has an ICD and a history of reduced ejection fraction, but no history of coronary artery disease. The mother
just before I forget, and anyone in her family have a history of sudden cardiac death, or I ask patients, have anyone died suddenly without a clear cause?
No history of sudden cardiac death in the family, though she has two brothers and younger brother has history of epilepsy. Social history, she works as an analyst, no smoking or alcohol history whatsoever. She does smoke marijuana 2 to 3 times a day. And the last was on the day of presentation on the morning. She drinks coffee 3 to 4 cups per day. She lives at home, no recent travel or sick contacts, and no non-drug allergies. And I think a couple of questions that you guys asked. She also didn't give any history of nasal decongestions. Nothing was in her medication history. I think that was And all the episodes were self-aborted. She didn't do any particular activity to make them abort.
Great. So that's a lot of good information. So we know, from the history that she hasn't had any associated symptoms of, infectious symptoms. It looks like no heart failure symptoms. So no leg swelling, no shortness of breath, dyspnea on exertion, and no GI symptoms. And also she's, it sounds like she's just a normal 29-year-old without any known, and then one thing I always like to ask though, is she a 29-year-old who's goes to her primary care every year, or is she a 29-year-old who hasn't seen a doctor since she was, 10 years old? So I don't know if Connie, you want to give it now, or I can keep going.
No, so she did visit her primary care about 6 months ago.
I see. Okay, so I think you'll tell us more about that visit and what was going on then. Other questions that come up for me is also this, it doesn't sound like she has family history of sudden cardiac death, but she does have this father with an ICD. You wonder, how old was the father when he had this ICD placed? Is he someone who got that when he was very young and he was having more of a genetic etiology for either a cardiomyopathy or a ventricular tachycardia, ventricular arrhythmia? Or is this someone who, is in his 50s, 60s and had ischemic disease and then got an ICD, which would be less linked to what I'm thinking about for her. And then the social history with, I don't really think of marijuana as predisposing a patient to arrhythmias necessarily. I would be more thinking about alcohol and stimulants. But so I think I'm thinking more that she could just have a native rhythm abnormality. Oh, and the other thing from the history is, we didn't get any symptoms of, hyperthyroidism. That is also something you always want to keep your eye out for. And I think, so I'm thinking more that something happened a week ago, which maybe we can ask more history on that. What happened when she was last feeling normal? Was there a change in her life that happened a week ago that could have predisposed her to these new symptoms? And otherwise, maybe she just has some sort of, reentrant circuit that just revealed itself now.
And just to make sure I remember each of the descriptive features, it's always abrupt in onset or kind of gradual in onset? Abrupt. Okay.
Abrupt in onset, last 30 seconds, and then it suddenly stops. She doesn't
On its own, without any abortive maneuvers. Okay. And does she describe it as just pounding or flip-flopping, fluttering in the chest?
It was more as a fluttering. She never described it as a skipping beat. She just said, my heart just races and then suddenly it calms down.
Okay. Great. So I think, is there any other information we should get from the history, or maybe we can summarize so we kind of frame our thoughts?
I think the only thing I forgot to mention was menstrual history was, she has been amenorrhea because of the OCPs, but apart from that, nothing else I got.
And this was definitely the first episodes of, this occurring 1 week ago, no prior history. Okay. And she had never been to an ER or an urgent care or seen anyone for this rhythm. Does she wear any type of wearable like an Apple Watch?
No.
All right.
Those are increasingly helpful as we get into this age of technology.
So I think kind of just to summarize her kind of one-liner right now, she's a 29-year-old woman with no known underlying structural heart disease, presenting with 1 week history of intermittent palpitations, abrupt in onset, lasting 30 seconds at a time, with no clear exacerbating or alleviating factors, and spontaneous in onset and offset without any associated heart failure symptoms or thyroid associated symptoms, and but does have a family history of someone with an ICD.
Yeah, and just to be explicit, I think, I think she's now falling more into the bucket in my head of probably an SVT, a supraventricular tachycardia, and the fact that it's so abrupt in onset. And specifically, it makes me think of, an atrial tachycardia. A reentrant circuit is what I meant was either an AV nodal reentrant tachycardia or a accessory pathway, which is the WPW. So the AV NRT versus AV RT. And less likely atrial fibrillation, atrial flutter, I think of less common in someone without structural heart disease. So that's kind of where my brain's at right now.
Exactly. And then VT, we'd have to prove she doesn't have underlying structural heart disease, but, maybe less likely in the context of her being young, no known disease, although there are some VTs that would be associated with, without structural heart disease associated. So still on the deferential, but like Lily said, those SVTs are kind of our top differential right now.
All right, thank you for that amazing discussion. So physical exam, when she first presented to the ED, temperature 98.4, heart rate 127. Her blood pressure was 125/75. She was breathing fine, 22, and saturating 99% on room air. She was AO ×3. When I saw her, she was not in any distress. No sclerolectrus, no conjunctival pallor, neck. I couldn't appreciate any JVD even when she was lying down. Cardiovascular, she had normal SNS2. I couldn't appreciate any murmurs, rubs, or gallops. Respiratory wise, she had normal vesicular breath sounds, no arid sounds. Abdomen soft, non-tender, neuro exam was fine, and she didn't have any pedal edema on exam. And her extremities were warm. Coming to the labs, her hemoglobin 13.5, white count 9.5, platelet count 263, sodium 132, potassium 3.4, chloride 98, bicarb 19, anion gap of 15, BUN of 9, and creatinine of 0.7. The random glucose was 124, calcium 9.4, phos 1.0, mag 1.6, TBL 0.6, direct less than 0.2, AST 20, ALT 9, and ALP of 30. CK was 76, troponin T was less than 0.03, which is normal in our lab, and TSH 0.917. We also conducted a U-Tox because we were concerned about her history with marijuana. So she tested positive for cannabinoids, but negative for any opioids, oxycodone, fentanyl, barbiturates, methamphetamines, or cocaine. She did have a D-dimer of 2.04. The normal is more than 0.5, less than 0.5. So it was significant, and INR was 1.0. Once you get on the labs, then I'll show you the EKG.
Thanks, so much information, Kanu. And I love, Natasha and Lily, how you talked about when we're thinking about like who is our host, as we say in CV solvers, as well as what the foreground and the background are, and how we layer those things in when we're thinking about this patient with lightheadedness and palpitations.
Yeah, I think one thing to add to that we didn't really talk about is also she's on birth control. So obviously a young woman on birth control, you also want to think about, thromboembolic phenomenon. And, always a young woman coming in. I know she didn't complain of chest pain or shortness of breath, but always in the back of your mind having PE on the differential too, that may have triggered these arrhythmias as well. I think of it being more consistent, like it would be like a sinus tachycardia, but it's possible that could trigger these arrhythmias. And with that elevated D-dimer, so that may be something in the back of my mind. But looking at the other vital signs, she's afebrile, her blood pressure is normal, with a normal pulse pressure.
The good news is her heart rate's 127.
Yes.
So hopefully we'll see something on an EKG. And if these are 30-second runs, it'll be nice to catch on telemetry, the onset and the termination, which will be important for the diagnosis if it is an arrhythmia, which we'll have to see.
Yeah.
I think, and then also to the point of just thinking about like triggers, you know, anemia, important to just kind of focus on. So if you're in an outpatient setting and this is happening, like the certain basic labs, you're not just, you know, there's a rationale for it. So, you know, the CBC looking for anemia, asking her if she's, you know, a woman, like if she's a menstruating person, if, you know, she has had a lot of blood loss, and assessing her risk, you know, and sinus TAC would obviously kind of go with that, and we'll get more of that information.
I think and just going through her labs, you know, her CBC is not that impressive to me. Her sodium is interestingly a little bit low, and her potassium is 3.4, so it's slightly low, and mag is slightly low at 1.6. You know, we're also obsessed with correcting electrolytes in the hospital. I don't know actually if we have any good data for that, but we do it anyway because we think that maybe it could contribute to arrhythmias. But otherwise, you know, I don't, there are some pertinent negatives here as well. You know, her liver function tests are normal. Her TSH, I think, is in the range of normal, the lower range. And then other things, her troponin is normal. So that's reassuring. And that's kind of what we expected based on her history in the exam. But it does, you know, if she was having a massive PE or something with right heart strain, you would maybe see the troponin be elevated. The other lab value that is always helpful for us is getting a BNP, just to see, you know, she doesn't have any symptoms of heart failure, but it's a nice kind of double check to make sure there's nothing else going on. And then her UTOX is as anticipated with, you know, cannabinoids, but negative for all those other toxins we talked about. So I think getting the EKG would be helpful to characterize what is this rhythm, and it's good to just hook her up to an EKG machine, because you may not catch it. You obviously want to have her on telemetry, but when you get your EKG, you may not catch it, but you may, you know, while she's on telemetry, you'll say, oh, she's going into it, and just hit the button and you can get a 12 lead. And that is so helpful for us in determining what the rhythm is.
And then just one other thing to round out the labs would be a UPreg. Just it's on my kind of list of to-dos for palpitation in a young woman, and exclude that.
Yeah, it's a great point. I think you're muted.
Yeah, sorry. Let me share the screen for the EKG. Let me know if you're able to see.
Yep, we can see yeah, we can see your slides.
So this was the first EKG at 5:50 p.m. when I first saw her. Any comments on this one?
All right, so before kind of, I see, you know, two wide complex beats of PVCs interpolated, but kind of before analyzing those in more detail, she is otherwise in apparent sinus rhythm, sinus arrhythmia, rates between 100 and 120. Normal axis intervals look relatively normal, although I'm trying to look for that PR, and you know, if there's a delta wave there, but I don't see that there. And then morphology, P wave morphology looks you know, upright in 2, coming from the sinus node otherwise, and then you know, I don't see any significant atrial enlargement, no signs of ventricular enlargement, and then no signs of ischemia. So I don't see any, you know, ST wave abnormalities that would suggest ischemia. And then finally, you know, those two PVCs, or I'm calling them PVCs because they're wide complex beats, but they're you know, a very fast rate between the two, very fast like cycle length, which is a bit concerning. And as far as, you know, we have an important thing is to get like 3 leads to localize, and so you know, here we have V1, V2, and we have lead 2. So we have some information, and that kind of looks like a left bundle branch morphology. So, coming from the right side. And if this is something hemodynamically tolerated, and, she ends up having structurally normal disease, which we're assuming, but we'll prove with an echo at some point, thinking about things like RVOT, VT. Basically, I'm walking through like specific types of origins of ventricular arrhythmias, for which like the therapies will differ. And, I think another 12 lead when we catch this wide complex tachyarrhythmia, which I saw a brief, so that's why I'm calling it wide complex. But I think there's probably another EKG with that, so we can look at it.
Yeah. And I saw in the chat, someone said, oh, this looks like an irregular rhythm to you, which is a really good point. In the way that whenever you think of irregular, you think, oh, AFib, but you actually see discrete P waves. So, there's atrial activity. And at the beginning of the strip, we see the rate is pretty fixed around, around that like 127 that was reported. And those look like sinus P waves. And then you see some, Natasha called it sinus arrhythmia, which is where you get some variation in how fast the sinus rate is going. So, and that may be an atrial, that may be a different, and you look at the morphology of the P wave. If it looks the same, it's coming from that same SA node, but if it looks a little different, maybe it's coming from somewhere else in the atrium. But I think other things, so there is some,
and depending on the pattern, like sinus exit blocks can look like sinus arrhythmia, but I don't think that's like worthwhile to kind of jump into here. I think I would just call it sinus arrhythmia, and then because we're kind of trying to focus on that tachyarrhythmia and what's going on there.
Exactly.
All right. So this is what happened about 2 hours later when we hooked her to the tele. Here we only have 3 leads. So if you want to comment on these, or if you want, I have a 12 lead as well. Which one would you like to see?
Well, the kind of things I can take away from this so far is tune in ABF, the inferior leads are very positive. So it's really coming from the base of the heart, somewhere very high up and pointing downwards. I'm often like when I'm trying to read AKGs, like pretending that the leads are cameras. And so right here, as I'm talking, I'm thinking about it going this way from the base and out towards the inferior leads. So my suspicion is even higher for like an RVOT origin if we prove that she's structurally normal because of that orientation so far. But let's see the 12 lead.
Yeah, and that means right ventricular outflow tract origin, which is at the base of the heart, and those inferior leads are inferior, so coming from high down low, so anterior to inferior. And then
versus like if it were apical, what would it look like?
Yeah, it would be positive, right? Because it's going towards, negative, because we're going away from those leads. So, and then also same thing. So maybe go to the 12 lead, and then we can localize where we think this is coming from, see whether this is ventricular tachycardia because it's wide complex, or is it an SVT with aberrancy?
Sure. So this is the full 12 lead. It's too squiggly. Are you able to see, or you want me to zoom?
I think we can see. So this isn't like a classic. This is like what is this called when they're presented one after the other. It's not in our typical EKG format. And so I think the things that we want to do, which Natasha is where we'll do this together, is to kind of figure out, is this VT or is this SVT with aberrancy, which means it's coming from the atrium, but there's a delay in the conduction. So it becomes wide and it ends up looking like a bundle branch block. And we all know about our left and right bundle branch blocks, where you go to V1. And so I think that's where, we'll start and say it's mostly negative in V1. So as Natasha said, it looks more like a left bundleoid morphology. But then the question is it a typical left bundle, to know if it is aberrancy or not? So then you look more at the lateral leads to see whether they are upright, which they are. And, usually for VT, it's actually probably more helpful for us to go through our criteria to kind of look for things that would to make us think, is this VT or not? So one of the major things we look for is for AV dissociation. And so Natasha, maybe you and we can go through this and see, are we seeing some AV dissociation? I'm wondering whether right here we're seeing some
because it
atrial activity.
Yeah, it looks like atrial activity. It's hard for us to, because I can't, it's so many beats, it's hard for me to count out there, but then further on the strip, you can't see it very clearly. And, you know, kind of one way, even though there's lots of pieces to put together to decide if something is VT or SVT with aberrancy, and never with perfect accuracy, but to some degree of, you know, of certainty, you kind of put those pieces together. And one way to kind of anchor yourself is algorithms like Brugada's algorithm, and what you would go through is kind of look through the steps to characterize as this VT or not. So you really start with, is there precordial concordance? And that just means, are all the precordial leads with the same polarity going in the same direction? And here there's clearly not. So you're starting, you know, negative in V1 and positive by V6. Why is that a criterion? It's because basically the leads are all situated on your chest. And if you have VT and it's coming, you know, straight towards your anterior chest, that really can't be from, and that's positive concordance. And then negative concordance is when it's going all the way backward, starting like at your chest. And, you know, if you have concordance like that, then it's probably coming from below. So that's why that criterion is one of the first ones. And then then you're looking for like a slurred onset of the S wave. So from the R to the S, you know, the Brugada criteria uses like a time, like an amount of time, so 100 milliseconds. But you can also just look for like notched or slurred S waves. And that looks a bit like it could be, but, you know, for the sake of argument, maybe let's say it's not, because as you walk through the algorithm, you go, is this here? Yes or no? And if it's not, you kind of continue on. So then AV dissociation, we thought, you know, we saw some atrial activity, but I can't be certain. I don't see any fusion or capture beats. Do you?
So if we get AV dissociation, that's a slam dunk. If we get fusion or capture beats, those are a slam dunk. And that means either a fusion is you're catching the sinus is firing and it's depolarizing through the normal pathways at the same time that the ventricular beat is happening. So it looks like it's a narrower beat than your wide complex beat. And then the capture beat would be the just the normal sinus rhythm getting through. And I actually do see, and so the question is I actually think we may be seeing some AV dissociation, because there are some beats where there's this little deflection right after the QRS that I'm seeing in a lot of them, but I'm not seeing in all of them. So that makes me suspicious for VT. And then, and I think just the way that it's hard for us, and we know that there's no concordance. We know that, let's see, is there that?
Well, and then after AV dissociation, so if we're satisfied AV dissociation, then, you know, we would say it's VT, but we could even go to the next step and say, you know, morphology criteria, which you were mentioning. So like it's left bundle branch like, now, is this a true left bundle, or is this just left bundle looking but coming from the ventricles? And that's what those morphology criteria kind of help you with. So we can look at V1 or V2 and V6. Try to see,
which are positive.
Yeah.
And then the other thing is axis, which is easier when we're looking at the typical 12 lead, but I think that we have it positive in 1 and positive in 2, unless that's overlapping that 1. Is that negative in 1? That may actually be negative in 1, in which case it's a right
lead
axis
1
deviation.
is like, yeah, I wish I could see that in a little more detail, lead 1, but
and then the other trick is you can also look at AVL and AVF if you and those and actually those clearly we can see, so they are pointing towards each other, so it looks like that's consistent with a right axis deviation. I think AVL is negative and AVF is positive.
Okay.
Yeah.
Is
So
that okay?
So that's also more suspicious for VT. Like a left bundle with a right axis deviation is more suspicious for that.
And then AVR and AVF, this is just for my own, look like they're the same kind of polarity. Okay.
Yeah. Okay. So I think I'm leaning more, actually, surprisingly more towards VT actually than we were just based on the history, seeing the rhythm. But we could, and you always want to treat it. It's, VT is until proven otherwise. And someone who has a structural heart disease, it's always VT until proven otherwise. But I think we'll treat it as such. And maybe we can see if you did any maneuvers or if you guys gave any medication, see what happened. Or you can ask us what we would do.
That V6 looks kind of typical though. So yeah, hard.
So yeah, we continued that, and as you saw, it's the same continuation, and then it suddenly stopped after that, and then these are the new beats, and then it reverted again. It kept on going like this. So basically, it was a non-sustained ventricular tachycardia, which later turned into repetitive non-sustained VT.
Yeah, you can see at the onset, like you don't see a P wave, you don't see it buried within the T wave that's preceding, and then those, wide beats. And this is also very fast, very fast. Like that's, just an extra piece to be like, I'm concerned that
like almost at 300.
So, you want to really be concerned about our hemodynamic stability and monitoring her closely.
And now we know why she's been lightheaded with these episodes.
Yeah, I'm not surprised.
Yeah.
Do you guys have any comments on the termination, on it's very natural for the VT to just terminate naturally, or?
No, that's a great point. So like, usually it won't, unless sometimes there are certain type forms of VT, I think, that have shorter like runs and spontaneously terminate. But, usually you'd probably see, longer runs, and especially it's causing more hemodynamic instability that would only like perpetuate the situation.
So basically that's kept going on, and then suddenly she went into another run, and that's when we gave amiodarone infusion at the time, and then it stopped, but it kept coming back. So then we put her on maintenance. After the loading, we put her on maintenance, and since then she's been like that. She did have a little bit of couplets on and there, but she didn't have a full-blown NSVT or VTAC after that. And then the next day in the CCU, her strip was perfectly fine after that.
Great job. And I assume you had pads on her the whole time, just in case.
Yeah, we did. We did.
Did she ever require any shocks?
No. She
was ever hemodynamically unstable?
She was stable the whole time, fortunately for us. So give me 1 second.
Maybe just while you're pulling that up, for someone with VT, we always like the first thing you want to think about is there ischemia going on? And in a young patient at 29 years old, it's very, very unlikely, but it's not, you definitely could have it. She could have had like a cardioembolic, MI, but the fact that her troponin was negative, and then that post ECG didn't show any ischemic changes, it's unlikely to be the case. She may just have some underlying structural disease that we don't know about. And we can do some other diagnostic imaging to take a look.
Yeah, and of course I'm like want to jump into things like origin, et cetera. But one thing, remember that we start with SVT versus VT, and then characterize the morphology. So when you're trying to figure out, is this, what is this rhythm? You just describe it. So the way I would have described it, writing a note or kind of discussing it with Lily and trying to figure it out, it's like, okay, so wide complex monomorphic VT. If it were polymorphic VT, I'd be more concerned for, other triggers like ischemia, although she is young and that's unlikely. One thing that I think often like took me a while to get, but often gets missed is like Brady-induced torsades, because like, you know, the context of the rest of the situation is important. If someone's bradycardic and their QT is long, you know, and they're having runs of NSVT, that's a herald for, you know, a polymorphic VT arrest. And that's something where you can like intervene really quickly by giving them magnesium, and making sure you're there to intervene with defibrillation if they go into sustained run or get hemodynamically unstable. And they're, in addition to like tanking them up with bag, there are other things to do, like making sure their rate is up, because the bradycardia will, you know, trigger, exacerbate those runs of NSVT, which turn into sustained VT. So those are kind of ways you can like anticipate and intervene. That's not the case here, but just as you're thinking of your very broad differential for, you know, monomorphic wide complex tachy. Except it's not, yeah, and it's not polymorphic.
Yeah.
So all of those other things are kind of like less or out of the, you know, out of the differential for now.
And just to be explicit, monomorphic means it's the same morphology, right? So it's coming at, and it's usually from scar, or it can be a reentrant circuit. But the polymorphic VT is usually has different morphologies, so polymorphologies. And usually it's that R on T phenomenon, either from ischemia, or you have, you know, long QT from drugs, or severe bradycardia, like Natasha was saying.
Yeah, and then you're going to want to avoid QT prolonging medications and certain drugs.
Right. So we did initial investigations. Chest X-ray was normal cardio-mediastinal silhouette with no acute abnormality. CTPE was also done because of the raised D dimer, didn't show any acute PE. She did have some micronodules in the right middle and left upper lobe, but otherwise it was normal. The heart was not enlarged. There was no pericardial effusion. Thoracic aorta was non-aneurysmal, and a normal vessel aortic arch with 3 vessels was seen. We also got an echocardiogram, which was transthoracic. EF was 65%. RV function was normal in size and function. No significant valvular abnormalities. A normal LV diastolic function by spectral flow. Wall motion was normal. RA and LA size was normal. Mitral valve was normal, no prolapse, and she had a trileaflet aortic valve.
Okay, well, that's really helpful, because we've been kind of hoping, based on our history, that her heart was structurally normal and kind of thinking around that, but very important to prove, especially if we're talking about like sites of origin and the right ventricle, and that might, you know, based on certain types of cardiomyopathy, be the trigger. So, you know, it's a really important thing to characterize for her.
And, you know, the other thing is, in a young woman, you can think, who's having ventricular tachycardia, you can think of other conditions, for instance, ARVC, so right ventricular dysplasia or cardiomyopathy, can cause this. And I think, I can't remember, but I don't know if there's some association with low K or something, but maybe I'm making that up, but I would look that up. But you get basically fibrofatty replacement of the tissue in the right ventricle. I don't think, you know, the echo may not be totally sensitive for that. So that may be something that I would want to get a cardiac MRI to better evaluate for, which, yeah, I see you smiling, Kanu, that maybe we're headed that direction. But it also could be just, you know, something else, some other place of scar that caused this. But it's interesting how it just suddenly started a week ago. It always makes you wonder what it was that tipped her off. And then it's good to know that she doesn't have a PE. Other good things, you know, you can see for someone who's older, this is more helpful, but while you're getting a CT, you can always look for coronary calcifications too. Less helpful for younger patients who may have non-calcified plaques. And then for her, and then I think I had mentioned earlier this idea of a cardioembolic MI, where you know, we have this phenomenon in women where we talk about a Minoka or something, where you could actually have some sort of myocardial infarction, then the coronaries are clean. But another form of that is where you could have obstruction that then kind of dissolves, and then the coronaries look clean. And if she had like a DVT that then went up the venous system, and she had a patent foramen ovale, and it went across, and then happened to be so unlucky that it went down to the coronaries and then dissolved. You know, that's a possibility, but for her, I think very, very, very unlikely, because her troponin was negative again. But going back to just thinking about next steps, I think I probably would want to get a cardiac MRI to see if there's any source of scar or other structural disease that we're not seeing with the echo.
And then, thinking back to the morphology, and the site of origin of the VT, I would have to see it again and for you to agree with me, but I think it looked like right ventricular outflow tract location, and she kind of fits the description. She's young. It has a predilection more women than men, happens in, young to middle-aged women, structurally normal heart disease, does usually kind of, occur with more catecholamine sort of triggers, so exercise, stress, which she didn't give us, but doesn't exactly have to be there for the diagnosis. And then, these runs of non-sustained episodes would also kind of fall in that bucket.
Mm-hmm. And we can use the EKG to localize it, like Natasha said. So it was a left bundle looking, so it's more on the right side. And the fact that it was positive in the inferior lead, so it's going from top to bottom. And then you can use the lateral leads to know whether things are like the one an AVL to see if the origin is coming from the septum or more the lateral wall.
And if this is all like totally foreign to you, you can, that's totally normal. I remember being an intern on rounds and someone asked me, where's the VT coming from? And I said, huh? So like it helps ultimately, but figuring out your diagnosis and then also kind of your treatment plan. So, structurally normal disease, this is coming from the RVOT, and the mechanism's a bit different. So, it's from an automatic focus. That's something that could potentially be easily ablated versus something, re-entrant around a scar. And then, knowing based on the surface EKG, like where this might be located might also help you plan, an eventual EP study and ablation. But we'll see what the cardiac MRI looks like, make sure she has no structural disease.
So before I go into the final aliquot and reveal the diagnosis, I'll delve more into the hospital course simultaneously. So obviously she was given amiodarone, she broke the rhythm, but then she became bradycardic and hypotensive, so we had to switch her to PO amiodarone. She was seen by electrophysiology, who recommended to continue amiodarone and consider life vest, but she became anxious and she refused. She was then transitioned to metoprolol 50 milligrams BID. She was started on aspirin, also after a cardiac MRI. I'll tell more about that. So the cardiac MRI, left ventricular was within normal limits. There was a concern that she has non-compaction cardiomyopathy in the in the right ventricle, though it was like borderline levels. She also had normal global RV systolic function, EF was 66%. Otherwise, no significant valvular abnormality, no pericardial effusions, and no intracardiac thrombus otherwise. So the main thing was the ratios were kind of borderline. They just fall below the cutoff of 2.3, but because there was involvement of papillary muscles, that kind of made them support the diagnosis of a non-compaction cardiomyopathy. And then that was kind of the diagnosis. We also did a genetic testing in which we found a genetic mutation in vinculin gene, but it's still of uncertain significance, but that's a cytoskeletal protein that kind of binds it. So she was found to have a non-compaction cardiomyopathy as a substrate for her RVOT.
And I don't know if you have the report in front of you, but did you say that it had late gadolinium enhancement?
Give me 1 second. I do have the report. So it's non-specific linear mid-myocardial enhancement in the basal interseptal segment.
Okay, so I think, non-compaction cardiomyopathy is a diagnosis that I think more recently has been getting a lot. It's a little controversial because I think we sometimes overdiagnose it, and we think it may be an entity that's part of a whole spectrum of, a spectrum of types of cardiomyopathy. It's not necessarily its own class, but I think in her case, without known other slam dunk diagnosis. She has some underlying cardiomyopathy that triggered this VT, that she has some underlying scar as evident by that mid-myocardial scar. If it was an ischemic problem, we would see that LGE in different locations. So you would see the subendocardial layer getting affected first because it's the most distal part from where the epicardial coronary arteries are supplying. So it's the area first being starved of oxygen when there's a lack of blood supply there. And that mid-myocardial enhancement makes you think more of something that's intrinsic to the muscle, or some sort of even myocarditis can cause that as well. And then there are other, features on the MRI that is probably beyond the scope of this episode that can kind of help you differentiate whether there's edema, whether there's the fatty tissue replacement versus whether it's more fibrosis. So, but I think that it makes sense that she, has, and then getting to genetics is really interesting because we really don't understand. We're really trying to uncover what causes different forms of cardiomyopathy, and these variants of undetermined significance. We don't know. We don't have enough sample size yet of enough people being genetically tested to know, how significant those genes are. But the more classic ones, when we think of genetic cardiomyopathies, are these, tighten truncating variants and other kind of variants that shorten proteins and make them not functional. But this is a really interesting case, and it's terrifying. This 29-year-old thinks she's so healthy and then comes in with these symptoms so suddenly. But it's good that she's been diagnosed. But it's interesting. So her ejection fraction is normal, and so you're not necessarily going to put her on goal-directed medical treatment, but you want to prevent these arrhythmias from coming back, and then monitor her closely over time to make sure that she doesn't develop heart failure, whether that's with preserved ejection fraction or reduced ejection fraction. And Natasha, you have other.
Yeah, and then I would just make sure, I would characterize this not as our VT, because that's usually associated with structural heart disease, but she's having VT in the context, or associated with someone not having structural heart disease, and then that mechanism of an automatic focus. Here, it sounds like she does have structural disease, and it is coming from the RV, and that's kind of why it looks like that. And so just so she has non-compaction on the
right side,
on the right. And what's happening on the left? I'm just curious actually for you, Lily, to teach me, if someone has ARVC, how are we going to differentiate that from right-sided non-compaction?
Yeah, because it's really interesting, because I feel like I don't think of, so arrhythmogenic right ventricular cardiomyopathy, usually they would do other evaluation looking at T1 weighting and T2 weighting, which is totally beyond the scope of what we're talking about. And so you can, but I don't think it's always a slam dunk, and we're still learning about cardiac MRI too. So she very well may have that condition. But it seems, I feel like I don't know enough about right ventricular non-compaction to know about it, but this just shows you how great medicine is, that, we're always learning. And I think constantly, Natasha and I are always looking things up, and there's, and in this case, I would probably go and kind of look up the literature on that. And I don't know if Connie, you did, and you can teach us more about it.
No, I was also surprised. I tried to look it up. I couldn't find major details, especially on the imaging. So we are still trying to look up. We did get a follow-up MRI as well. I don't have that report yet because we did want to see whether it progressed or did it improve. So once I get that, probably I'll share with you definitely. Apart from that,
I wonder if in this setting too, looking up the literature and what are the imaging findings, but would a biopsy here be
useful?
I don't know.
And it would be easy to do.
But I mean,
it's on the right side.
At the end of the day, it's is this going to impact your management?
Yeah.
So how are you going to manage her long term? And then what do you down the road looking for as far as her prognosis and what kind of surveillance and follow-up she needs? And she's had she's had a sustained VT episode. So
Yeah,
does
I'm
she
a
need
little
an
I'm a little
ICD?
confused. So they discharged her, you guys discharged her with a life vest, and was that to
No, we did not. So I left that part of the story right there. So after the MRI, because we found the substrate, we took Natasha's specialty into account and then we ablated her. And after the ablation, she didn't have any symptoms so far. We did get a repeat MRI after the ablation, but I don't have that report. She was taken off the aspirin. We didn't feel like she needs to be anticoagulated for the non-compaction cardiomyopathy at this point. She did have an incident of pericarditis about 4 weeks after the ablation procedure, but she responded well to the NSAIDs so far, and she's doing well in the follow-up.
Great. Yeah, that's a great point. So like, we're often seeing very similar causes of cardiomyopathy and VT. And so, in a low EF situation or where there are clear indications for ICDs, and here, you found a potentially reversible cause and you ablated her. She's, it's not reversible in terms of the substrate, but potentially that's the focus. It'd be interesting to see what they found in the mapping in the EP study. And, that's kind of a gap in the literature where, the right management would be to kind of figure out, well, can you prevent this from recurring safely and then manage a young patient without an ICD long-term, which would really be nice in her case. So, so it sounds like that's, you had to kind of go through the gaps in the literature and the guidelines to come up with a plan for her.
Mhm.
I mean, even though it describes, reversible causes, but that's not always very well characterized for clinicians to kind of use when they're in the thick of it and taking care of a patient who's, got a malignant ventricular arrhythmia.
the art of medicine?
Yeah.
Thank you so much for this case and discussion. I love how you guys localized it to the right side, right ventricle, just looking at the EKG, and the whole discussion just been so rich. And do you have anything else, Connor, before we turn it over to Shema for teaching points to wrap this all up?
Nope. I think that's it. I think I shared the genetic mutation. I can label it again. It was in the vinculin protein. Yep. So that is kind of the final diagnosis.
Yeah, thank you so much for presenting this, and thank you, Natasha and Lily, for sharing all those teaching points. And Shema, do you want to take it away with the teaching points?
Sure. So thank you very much for the discussion and also the case. And I have to say, I learned so much, especially about VT. So coming to the teaching points. So we had as a chief complaint lightheadedness and palpitations in a young patient. And the key questions to ask is this a regular rhythm, and also ask for maneuvers that can trigger it, like any high intensity exercise. Also important questions, does this patient have SOB, chest pain? Is it, and also the question, is it hemodynamically relevant? Because then we would rather think of a pre-syncope. Also, since this patient is very young, so we were thinking, is there any congenital disease or any structural heart disease? As we know, think of VW, PW, where we have short PR, broad QRS, and this delta wave that we mentioned. And also think of drugs like binge drinking, alcohol, coffee, energy drinks, over-the-counter medicines, and also for IV drug abuse, like looking for any infective symptoms that could lead to sepsis, and also endocrine diseases like thyroid. And in terms of atrial tachycardia, as we know, we should think of SVT, where we have an abrupt onset, and also, as we know, we have AVRT, where the common form is WPW, and also other forms like AV NRT and atrial flutter. And since this patient took birth control and had took birth control, we were thinking of a thromboembolic risk factor, which could have led to pulmonary embolism triggering sinus tachycardia. And also a very nice thing that was mentioned about sinus arrhythmia we have an irregular rhythm, and usually we tend to think of AFib, but as we know, in AFib we don't have notable P waves, and in sinus arrhythmia we have notable P waves. And the key question for tachycardia is also, is it in the atrium where we have a narrow complex, or is it rather ventricular tachycardia with a broad complex? And here are the key factors to think of, that this is likely a ventricular tachycardia when we have very broad complexes, an AV dissociation, a precordial concordance, and if all the precordial leads show monophasic S-waves, or if we have fusion or capture beats, and also structural heart disease or any family history with sudden cardiac death could be a clue to that. And in terms of the VT, also look, is it a monomorphic one, which could be due to a scar, or is it polymorphic, where we could have triggers like ischemia, which is mostly due to R on T phenomenon, or if we have a long QT syndrome, which could have been triggered due to meds like antibiotics or torsades, where we now give magnesium as a therapy. And now collecting the clues, we have a young patient, and we were rather thinking of a structural heart disease since troponin was negative, so it's rather no ischemia. And other things, differentials to think of were ARVD, Minocar, or also a DVT, which could have led to a pulmonary embolism and then a dissolved thrombus, which is very seldom. And also now coming to the end, so we had a non-compaction cardiomyopathy, which was triggering these ventricular tachycardia, and it has a genetic mutation as an etiology. I never heard of it before, so it's a very cool case, I have to mention. Thank you very much.
Thank you so much, Shema. That was such a great recap of the entire case and teaching points. Thank you everyone for joining, and thank you again, Kanu and Natasha and Lily, for the great case and discussion. And it's a perfect, I guess, combination of EP and heart failure that turned out to be a good combination for our future EP and heart failure.
Definitely. We do this all the time.
Yeah, we love talking through cases. So thank you for letting us do it with you.
Thank you.